Of you once again. Today's topic of discussion is handling aggressive patient party. And as I was mentioning that usually if you're able to manage and resolve patients' complaints or requests in a very responsible way, you or your team, you can actually prevent aggressive reactions. A lot of time, patients, they become aggressive because of these small issues that are not addressed, and somewhere patients feel that they have not been heard or their requests have not been entertained, and that ultimately ends up into the moment they get a chance they can become aggressive. So if I may ask all of you, have you ever experienced aggressive reaction from patient party? Anyone? Has anyone of you experienced?
Yes, ma'am.
So if you could share your experience briefly about what kind of, I remember Dr. Menon has, Dr. Manisha had mentioned about the situation she had managed when the patient became aggressive and she literally, threw her out. I remember last time she was talking about it. So anybody else, if you have any experience to share, raise your hand so that I know who all are willing to. Yeah, okay. Dr. Neha has raised her hand. Go ahead, please, Dr. Neha. What experience would you like to share about handling aggressive patient party? Yeah. Unmute your device, Dr. Neha.
Sorry. So this was a patient who came through the emergency and was put in ventilator in ICU.
Mm-hmm.
And she was somewhere around 40 years old lady, multiple problems.
Mm-hmm.
And within 2 days in the night, the next day in the night, she expired. She was really sick and she had multiple problems. So in the night, late night, came to know call, received the call from the ICU that patient party is very aggressive and all. So I reached early in the morning around 6:30 or so. And but it happened so that same time when I entered, the patient's son also entered. And he in front of me slapped the doctor on duty at that time. Immediately he just rushed inside because probably, not probably, in fact, in the night there was a guard there, so the door was locked because of the aggressiveness. Many people had gathered outside the ICU. But since as soon as I entered, behind me, the son also entered, and he just charged past, and before I could say anything, he just went inside. And the doctor on duty was there, and he tried to speak to something. He just, without saying anything, slapped the doctor. Then I tried to calm the patient, and then the guard also came and tried to stop. He was going to hit more times to the doctor. Then I also tried to talk, but he was crying, and he was just shouting that you have killed my mother, you have killed my mother. And then there were lot many other relatives also, somewhere around 7-8 people, those who came inside also together. Those all more of a, jamindars type people. And, so there was a doctor's duty room there. Somehow I counseled them, okay, let us talk. Please, there are other patients also, and I will talk to you. And I requested them that please, any 2 or 3 people can come. I have no problem. So the son also came, and then some more elder people, the old people. So they, I sat with them and tried to reason out with them. And somehow, I could calm them. Probably, I would say here something, probably, of course, I talked in a different manner, but there was one factor. I'm sure that I was a female. I'm sure if maybe a male doctor would have been there, I don't know how they would have reacted. Maybe they would have hit the senior doctor also. So that I would admit, probably I felt that advantage at least I had, although I was very scared from inside that even then they might do something to me. But somehow I took the courage, sat in that room, talked to them, reasoned with them. Then there were other people, they wanted, the other people also want to they have some queries, they want to say something. So I let them all in, because I didn't want, I said, okay, fine, whosoever wants to come, I am sitting here, I am ready to answer
So,
all your
Dr.
queries.
Neha, I'm sorry I'm stopping you, because if you will tell us the situation in this much of detail, probably then we'll be able to know from you, but we want to learn from that. So I want to stop you here for a reason. One, because I want Santoshi and also Sneha to talk about their work situation, because both of them have a different kind of work situation. For example, Santoshi handles ambulance services. So I'm sure her set of challenges are very different. I want Santoshi to talk about situation that she has seen. But I will request everyone to be very brief, because we want to, take that situation as a role play. Maybe if we find something, interesting to learn from, we can take that as a role play. And of course, from Sneha also, Sneha, if you have any incident that you can share, both of you, and Mamta, because Mamta is from nursing, wing. So probably she will also have certain situations where nurses have been manhandled or patient part. And usually, before they start hitting anybody else, they are usually, aggressive with the nurses, because that is where they can throw their tantrums. And if that gets unnoticed or unattended, probably that is where their anger actually escalates, and then they go to the extent of hitting. So, Mamta, have you had any experience where the nurses have been hit in your like in your hospital or anywhere they've experienced something like violence against them? No, I'm not able to hear you. I think your device is on mute mode. Yeah.
Yeah, ma'am. I have worked in NICU for an year. So
Mhm.
I have a couple of experiences, because moreover, the patients will come, they'll think that their baby will get discharged tomorrow or day after tomorrow. Again, the premature babies, sometimes the situation get worse.
Yeah.
Not only the baby's parents, but the mob will come. Sometimes it is very difficult to handle the mob. So they'll blame the doctors, they'll blame the nurses. Then probably the head of the hospital has to come and they have to intervene the situation. Yeah, I had these couple of things, ma'am. So to avoid all these situations, we as a nurse, we are told not to give any information to the parents, their progression or devastating situation or whatever.
Yeah. So, Santoshi, if I may ask you to talk about your work situation, anywhere that you have personally witnessed violence or aggressive reaction.
Yes, I'll share two incidences, and first is which I experienced, and one as a reporting manager, I got to know from my reportee when he was handling a case. So here, when I started my career as an ambulance supervisor, and it's long back, it's many years back, but in that particular scenario, I was there with the paramedic. I went for a quality check of the ambulance, and my work is to also inspect that how the paramedics are handling the cases, especially how they are giving pre-hospital care in that particular medical emergency. So we got a case where a victim, he was almost 45 plus, and he was in an intoxicated case. It was like he was alcohol overdose was there, and already the call has come from police that because he was driving, he had met with an accident, and that case we were supposed to cater. So the ambulance which I went for audit, it was nearby, so that ambulance was dispatched to the site, and I also went with the paramedics. So they handled the case, and the patient was very heavy built, very aggressive. Why? Because he was completely drunk, and he was not in a conscious state, like he was not into his conscience. So what happened, we gave pre-hospital care. He had some head injuries, some knee injuries, abrasions, and few lacerated wounds were there, which paramedic handled very well, and we transported that case to the nearest government hospital, city government hospital, and we were just coming out of the hospital. Everything was done, handing over was done to the ER doctor, on duty doctor, and we were coming outside immediately. That patient, he came outside of the ER room, and he entered into the ambulance quoting that his belongings we have stolen. like whatever he was having, his pocket or rings or chain, he was claiming that the ambulance staff has taken all those things. Though we were kind of assisted by the police also, and police was inside finishing up all the MLC formalities with the ER team, and immediately came outside and he did so much of drama there, and even police was supporting us. But there I met personally that experience where I felt that he was completely over us. And I, being very young, and this was the first ever case which I encountered with the patient myself, like along with the paramedics. So now the paramedics were dependent on me because they were reporting to me. So in that case, I was completely blank that what I should do. So here, he was completely intoxicated, and he was saying that he will will do case on us, and you have stolen my belongings while transporting for this many kilometers. So then the family members came, and I spoke to the wife of that person, and and then she said that okay, madam, please, as he is drunk, he's not in his state, so you do not do anything, because the police was also supporting us, and as a and leading an organ, because that organization which I was leading at that time, it was a very reputed organization. So it was like my manager has completely said that if something goes wrong, you directly complain against him, because police was also there. So then somehow after that communication with the lady and with her son, so the lady and the
Thankfully, they were on your side, so you
yeah,
could.
yeah. So that led us, like I was like, okay, then we will let go that patient. But that 15 minutes, 10 to 15 minutes, there was a complete chaos. The whole ER team, along with the patients who were there in that ER and also the OPD, they were watching us. And as an organization, when I was representing my organization with the ambulance standing back, and my paramedic and my pilot driver who was there, it was completely chaotic for me how to handle that.
So
I
there's
immediately
also, Santoshi, I'm sure, I mean, there must have been some element of doubt in the hospital staff's mind also, that probably, yes, you all have stolen the patient's
yes,
belonging, and now
nobody
you're
from hospital supported us, ma'am.
actually
Yeah,
even
nobody
those
from
that
ER.
if they don't know, and if they don't know what kind of background you all hold, so there's a possibility they will actually trust the patient, assuming that yes, you have done that.
And nobody from the ER team or from that hospital administration, they came out and they supported us. So we were left in between, just my team and my reporting manager and our call center. And the second incidence which I felt recently,
Yeah, Santoshi, hold on. I'll come back to you for the second case, because I want others also to share their experience. So, Sneha, do you have any case that you wish to share where you have personally experienced violence against you?
But I myself didn't experience physical violence.
Mhm.
Ma'am,
Sneha,
I
switch off
have
your
only
video,
seen my
maybe.
postgraduates.
Yeah, switch off your video and speak.
Okay.
Maybe.
So my own experience violence has only been verbal. Physical violence, I have my postgraduates experiencing. There were, and I as a student also saw कि it was not directly on me, but the hospital ke windows ko todna. Like Santoshi said, from inebriated patients and children biting while putting cannula, वो तो हो जाता है. But the attenders, what happened with this particular case for a PG was the child was brought in a sick condition. We don't know what the communication went, because I'll tell you frankly that among PGs the communications are poor. But otherwise, this PG is a good, sincere fellow. What happened is the next, because it is an ICU, this fellow came pretty late. The child was already morbid by then. And then the attenders only saw the last phase. They didn't understand the situation till then. And children do crash suddenly. They appear normal till pretty late, and then they sort of crash suddenly. And they started beating him. They started looking for him, and this fellow had to, they kept roaming around the hospital for a week to get hold of him. So we had to put him in hospital and not let him come out. And we had to report to the police, and it took a while before he was comfortable coming out. And
so I think all of us have seen situations where we have either personally been affected, or we have seen our team getting affected. Something like this. So Aditi, you have raised your hand. Do you have anything to add?
Yeah, the case didn't happen with me, but it happened with my father. The
Mhm.
patient was admitted in a semi-private room. The patient locked the room from inside. चिकन ऐसे ऊपर लगा लेते हैं. Her
Hmm.
mother, his mother got sick and she died on the spot.
Hmm.
Then when he got to know, मतलब वो नींद से उठ के when he got to know what happened to his mother, he blamed the doctors, nurses, and everybody. Then my father went to the hospital at night at 1 or 2. Then the attendant has called everybody from his mohalla, and everybody tried to do violence against my father. So थोड़ा सा beating हुई थी, but then everybody tried to resolve everything.
So
The-
first you have witnessed it and your father has been affected by it. That's what you
Yes, so it was like mistake was of the attendants. They shouldn't have locked the door from inside.
are-
The
So-
nurse
so-
cannot go inside. Nobody can go
Yeah.
inside. What's happening with the patient? They have locked it inside and closed the door and everything, lights off and everything.
That's very surprising, actually. So if I may ask all of you, have you ever had any formal training on how do you handle aggressive patient party?
No.
Most of you are saying no. That means this issue is not discussed. And this
There
is
was a module.
Sorry. Sneha, is that you who's doing the talking? Dr. Aparna, are you in your clinic? Yeah, you can
Yes,
switch
my
off your
network
video.
is
One
very
second.
poor.
Dr. Aparna, are you in your clinic?
Hello.
Yeah. Are you sitting in your clinic?
Yes, madam.
So I'm just able to see you, but I don't see you participating. So I think that's going to be a loss for you.
I'm
as well.
listening to their experiences, madam, because my internet connection today is gone actually. So this is just going on mobile data. I'm listening to their experiences, whatever they are saying. I have the ear thing in my ear.
Thank you. So as you said that there is a module, I think Sneha, that's what you were trying to say, that there's a module. But it's
There is a module in AdCom, which is the medical education technology, but then I felt it is inadequate and the reach is very less.
Yeah.
Very few people are able to access it. And then when we teach also, the problem with all trainings कि सबको मिलके train करना नहीं हो पाता है. मिलके नहीं, कैसे भी training everyone, reaching everyone becomes a challenge.
So things like handling uncooperative patient party, managing complaints, handling aggressive patient party, these things need to be actually not done for just couple of people, but each and every staff member should know what is the protocol of doing it. As very clearly you all have said that we haven't had any training. So that means you are just left to yourself. If you know how to prevent violence, you will be able to manage. If you know how to control the situation or de-escalate the situation, I'm sure you will be able to do. But in case if you do not know, then you really do not know what to do. Then you just, you have to figure out in the spur of moment how I can handle, either I run away or I start fighting or I start arguing, but we really do not know what is the right way of doing, right way of handling that situation. Of course, just 1 second, Dr. Manisha. So in an extreme aggressive reaction, of course, we all know that safety is the only way to ensure that you and your staff is safe. We're going to talk about that. But much before that, what is the way to, first of all, prevent aggressive reaction? What is the reason why patients become aggressive? Can we prevent those reasons? Can we control those reasons? Can we fulfill the requirements so that the patient does not become aggressive? Probably that is the area I want you to focus on. Of course, we are going to talk about managing, different stages of aggression and what will work in what situation in a while. But definitely, I think much more than that, I would say prevention is always better than cure. We all know it's less expensive in terms of time, energy, effort. Even if you have to sensitize every staff member about handling complaints or handling uncooperative patient party, you have to create that culture where we all know what is the right way of handling these difficult situations. And that is why I picked up this topic, because we are normally not told how do you handle complaints or how do you handle patients who are uncooperative. And you have seen that all through I'm trying to empower you with the required skills that will help you to at least handle the situation in a more professional manner, in a respectful manner. So one experience that I want to share with you and also remind you that how just creating familiarity with the patient party can prevent violence. So if I may ask you a question, anyone has ever witnessed violence by a patient party with whom you have enjoyed good rapport, or who have had, a good relationship with the hospital staff and the doctors and the senior doctors?
Sometimes out of the blue, the relatives come and start misbehaving. Though the attenders have been fine till now, and everything has been, the understanding between the attenders is fine. The parents is fine. And even parents try to, even when the child dies, the parents try to, pacify the other relatives, but the other relatives start misbehaving. They come in the last moment.
So that means, first of all, knowing the primary caretaker, interacting with the primary caretaker, building rapport with the primary caretaker, updating them on regular basis, answering their questions. If you are able to do all this, trust me, your patient and the family is more likely to be satisfied with your conduct, your treatment, and your management. Unfortunately, when we miss on these things, so anger against us or our other team members start getting accumulated. And the moment they get a chance, especially if it's a death of a patient, see, till the time the patient is alive, they have nothing to lose. I mean, I'm sorry, they want your services, so they will always cooperate with you. The moment patient dies, they have nothing to lose. And that is a point where they are likely to become aggressive. And in that situation, if you have good rapport with your patient's party, they are more likely to cooperate with you. We'll take this discussion further, but I want Deepika to first, I think she wants to share her experience or probably talk about a situation where she has seen patient party becoming aggressive with the known to doctor or somebody who's familiar with. Yes,
Actually, it was not the patient party, ma'am. It was the patient himself.
Uh-huh.
Because, when I moved here, it was just a week's time when I was working as an OPD manager at one of the hospitals here. So the patient had undergone a surgery, and he had been repeatedly coming to the OPD to meet a particular doctor because he was saying that there were some side effects because of the anesthesia given. I was not completely aware of the clinical part of the case. But then I had a very good rapport with that doctor because he was from the same place where I was. So it was a very good rapport that I had with him. So just because I requested him to meet, he usually doesn't meet without appointments and things like that. But this patient was a local patient, and then he insisted that he really wanted to meet the doctor right away. And I didn't know what was the history or what had happened in his previous visits. So I wanted to help the patient, and I spoke to this doctor over the call, and then I just gave him a very brief description of the patient. And then the doctor was actually supposed to go for a surgery, but then he waited to meet this patient because I'm bringing the patient there. So there was a lot of things like that. So then I just opened the OPD and I took him inside. And within a second or two, he went and slapped the doctor. So the doctor was also shocked. I was damn shocked because that was my first experience of that sort in a different country altogether. And the doctor actually started hitting the patient back. So it was like, to and fro. So I was just literally watching, standing in the room in one corner. And then there was a lot of noise created. The nurses were there because it was near the IP ward area. So the nurses then immediately called the security ward and everyone. But one good thing is here, the police are very, very, active on that ground. So as soon as we make a complaint, they come within seconds. So once the police came in, he was completely a different person. So he was like, he acted as if nothing had happened, and he was completely a different person altogether. And then they made him to write an apology and things like that. And then a case was filed, but then they revoked because they didn't want anything to happen to the local. And so then it got resolved. So that incident still stays in my eyes because it was a very tough situation to handle.
So Deepika, just I don't know the complete situation, so it will be wrong on my part to make any comment on this. But from the narrative that you have shared with us, I think I do have a feeling that that patient had some anger against the doctor. So that
Yeah.
means something must have definitely happened in past, and this patient must have been really frustrated or unhappy or dissatisfied with the doctor. And the moment he got a chance, he kind of, you physically assaulted the.
Yeah. Yeah. Yeah.
So again, I mean, there must have been some conflict between the two of them. But honestly, having therapeutic relationship and familiarity actually saves you from the aggressive reaction coming from the patient party. So this experience was shared with me with a resident who was working in gynae department. So I was taking a session for a gynecologist. So one of the resident who was attending the program, she said, "Ma'am, in our hospital, we actually delivered a schizophrenic mother. She was, full term, and her husband was allowed to be with her in the labor room, and she delivered a normal, healthy male child, and everything went well. But because her husband was there in the labor room, so we got to know each other, and like we also had that kind of a comfort where we could talk comfortably with each other. So she became familiar with the patient's husband. So after the delivery, the patient was moved to the ward, and we know that in Indian hospitals we don't allow male attendant to stay with the female patient. So the husband was asked to wait outside, and a lady attendant was allowed to be with the patient in the ward. At night, unfortunately, after feeding this baby, after breastfeeding this baby, mother took her medicine and she went off to sleep. And in the middle of night, I don't know if it was the patient's attendant or who, somebody noticed that the child had turned blue and the child was not breathing. So immediately the doctor was called, and this resident says, I was the one who was on duty, at that point. I immediately picked up the child and I rushed to the NICU, and we tried to resuscitate the child, but we could not save the child. Probably the child had aspirated milk, and God knows what time he had actually already passed away. Now, this gentleman, this patient's husband, who was so well behaved and nice throughout with the staff and other hospital employees, suddenly became extremely, extremely violent. So he started hitting people, he started breaking furniture, he started breaking things, abusing people. I mean, complete, uncontrolled behavior. She said only one person with whom he was not misbehaving or he did not become aggressive. She said it was me. Because during that patient's stay in the labor room, this husband had interacted with the doctor, and they cordially kind of interacted, and they had built good rapport. So as a result, he did not, hit her. The message that I want to give here with this is, of course, we are going off the track because I'm here to share the protocol of managing aggressive patient party. But if we remember, creating familiarity actually reduces the risk of violence. And it's not me who is saying this. I can share you a number of studies that prove that if you create familiarity with the patient's family, they are less likely to be aggressive with you. For example, if you're driving a car, somebody hits your car gets damaged, you come out in anger and you feel like literally hitting that person. Of course, all of us are ladies here, so I'm sure we will not physically assault the person, but if it was a male driver, definitely he will go out and start hitting the person. But if the other person who comes out of the other car is somebody known to you, will you still hit that person? So this one message I want to really give to all of you. I want you to spread this across. Having having all security measurements in place is important. I am not against them. It has to be done because there are people who are just out of their senses. So you don't know how they might react. But generally, if you are able to create familiarity, rapport with your patient party, mostly you can, prevent aggressive reactions coming from the patient. Dr. Manisha, you wanted to say something. I think you can add your point here, please.
Ma'am, I just wanted to ask everyone who had shared their experiences that security is always there in the hospital, whether it is a small hospital or a big hospital. Nobody mentioned that they called security.
No, Deepika said that nurses called the security. She did make a mention.
No, it is Dr. Deepika shared later on, but initially before Dr.
Yeah,
Deepika.
so maybe they must have done, but probably while narrating the incident, they must have not, because I think usually it is the security that is called.
Yeah.
How effective they are in handling the situation, that
Security
And that is another question.
but
That is
when
another
a lot of
question.
mob, the one
Yeah.
security person cannot do anything.
The bug you never know.
exactly.
Kagal
Once
gyun
they are
Ma'am,
not
the security person or senior, whenever there is an aggressive person, not a
Yeah.
general security is called, a senior person is called, so that they can handle the people. And the person who is handling them at that point of time, he doesn't directly calls, but the people who are behind, for example, the paramedic staff, they will inform the security that this is what is happening. Please send somebody from the team. So,
So Dr. Amrit has really raised a good point, and I want her to explain further, because we normally say call security, and she says it can backfire. I want to understand on what reasons Dr. Amrit wants to say that it can sometimes backfire. I'm not disagreeing with you, Dr. Amrit, but I just want you to elaborate on this. Yeah.
Ma'am, I feel such situations are very emotionally charged. And if we call security, that is more like somebody is using manual force to diffuse an emotional situation. So sometimes people may feel like that instead of, just as you said, the communication is important. Pacifying them, empathizing with them is important. But security people may come like somebody is trying to stop them and going antagonize them, basically. So many people may rather behave rather more aggressively.
I agree. So sometimes knowing that there is security around, that fear itself can actually provoke further anxiety and overreaction. As an overreaction, they may become aggressive with the attending doctor. I understand what you are trying to say. So that means we need to have security ready in case if there is an aggressive reaction. Then definitely they should be able to intervene. But otherwise, if they get put on hold rather than asking them to immediately start intervening and taking charge of the situation, that definitely can backfire. I agree with you, Dr. Amrit. Thank you for.
I want inputs about as Amrit ma'am was saying, if it is not physically violent yet, but it is emotionally charged situation, I feel very uncomfortable calling the security, because like you said, it will trigger things. But then how to sort of subtly send the message, I don't know. We want someone to know that something is happening, especially in a big hospital. Security is far off. And frankly, when you asked why didn't anyone mention about security, I will not think of security, because I never had a good trust on that will solve things and they'll come on time. By the time they come, the damage is done.
Yeah.
So it doesn't strike, for me at least. Yeah. So
Sneha, the thing,
subtle messaging how to do.
So Sneha, you have to inform the security as soon as you can sense that this patient party can become aggressive. But they don't have to come into the visual picture. They can be there. So I normally recommend two-door policy in counseling room. So I always say counseling room should have two doors, because see, we are not able to sense the safety risk to the doctor or the person who is attending the patient party. Now, for example, I am sitting here. In front of me, there are 3-4 people who are sitting, and the gate is usually on the other side. For my safety, if I want to go out, I have to cross these people. And do you think they will let me go out? Especially when they can sense that I'm trying to run away, they're going to further catch hold of me and then going to hit me badly. So there has to be a two-way, two-door policy.
Most of our counseling happens bedside, and
we'll talk
I
about
don't know how to.
No, Sneha, we'll talk about that. I'm going to share that with you. And not just this, the next 2-3 topics all are going to talk about how do you really do it in a manner that your safety is ensured, plus you are able to, cater to your patient's need effectively. So if you have a room where the patient party is on that side and you can sense that now these people are not in my control, I'm trying to explain, I'm trying to, give the reason out with them, but they are just not able to see my point of view. And there will be a state when they are so much emotionally hijacked that they are not able to understand logic. No rationality is working with them. At that point, any amount of dialogue is going to fail. So probably there you will have to excuse yourself on any pretext. It could be that let me ask my senior to come and speak to you, or give me a chance. Let me go and see the notes of this patient, or let me see there's another emergency patient I need to see. So you have to just move out of that place, which I will be sharing in the protocol. I have yet not shared the protocol, but I'm glad that I'm getting so much of input from all of you that we have already started the discussion. So the idea is your safety and their safety both are important. So how do you manage that? Will definitely, Sneha was already out of the discussion. She actually logged out by mistake. So I'm sure her question is not answered, but she will get an answer when we will discuss the protocol. So should we go with the discussion, or do you want me to do a role play with all of you and see how we handle it? But this time, somebody who has not done any role play will be taking the chance to, do the role play. Because ultimately, you have taken a trainer's program. So I expect that tomorrow you will be training your healthcare professionals, and role play is the way to teach them how to handle difficult situations. So
Ma'am,
anybody,
ma'am, here as said that security, you may need to call security, but in our settings, where ambulances en route, they are on the road. We cannot even call anyone except our reporting managers. The paramedic will directly only contact, but many a times it is like they are left alone. Sometimes the phones are not reachable, network is not there. Sometimes while carrying a case en route, the ambulance breaks down. Maybe some technical fault is there and they are in the middle of the highway. So now they are carrying a critically ill patient where the patient attendants are extremely aggressive. So here,
I think such a situation should be actually foreseen by the management who are actually providing those services, and how do they intend to meet the need of the hour.
Anita,
that requires kind of brainstorming, that how do they make arrangements to first of all move the patient in another ambulance, so that at least patient care is not affected. And if you are able to
ma'am, the care continuum is there, but the problem is that the patients, attendants, they lose patience because it takes time for the arrangement of other
Santoshi, that is so true. And if, put yourself in that position. If the patient is critical and if it's my family member, I'm likely to put my control, because my emotions are actually completely hijacking my rationality. So there probably that rapport will come in action, that proactive communication, that okay, I have already communicated and there's a van on the way, or there's another ambulance on the way, or rather than asking another ambulance to come from another place, having a kind of a network so that a local ambulance can be made available. So this requires extensive working, like Uber, like Ola. It requires a lot of brainstorming. I just can't, have a couple of ambulances and say I'm available to move you to any part of the country, and then in between, if my ambulance breaks down, I don't have a second backup plan. So those things require to be planned at a management level, but that's definitely a very pertinent question. But in the capacity of the paramedical, if we can train them, how right from the beginning they have to be respectful, nice, cordial, and show that proactive care of the patient, so that the patient party feels that, the staff is very responsible. They are doing everything proactively. At least they would not be aggressive with the care providers. That's what I can immediately think of and say. So Dr. Neha and Dr. Aparna has raised their hand. Okay, one by one, I think you can share your concern. Probably then we'll cut down on the role play and we'll go and discuss the protocol, if that's okay with you. So I can see.
Okay, ma'am. If I can go ahead with what I'm trying to say.
Okay.
See, ma'am, what you are discussing with these people, because they are working in, I think, multi-speciality, and they are having ICUs and, OB-GYN setups and things like that. So wherein they have different situations when the maximum damage that can happen is the death, as you said. Okay, but in my scenario, what happens is we are doing cataract surgeries, we are doing surgeries. So even if suppose there is any complication with the surgery and we explain to the patient that, okay, this is so and so has happened, but there is a way to deal with it. And, we will go ahead and, take all the necessary measures and this and that. Sometimes, patient construes that as initially they are, as you said very correctly, till they are, hopeful of the treatment and till they are, cooperating, it becomes easier to, manage them. But one or two situations have happened in such a way that, in one patient is, it was so funny, madam, that the patient said the first time he came, he said that my brother is a doctor and I want to get my mother operated. And he himself is a small time journalist. So the minute he said journalist, madam, my antenna was raised. I said, no, okay, I have to avoid this patient at any cost. So I just played along. I said, okay, fine. Then he said, no, you talk to my brother. And the brother is a doctor. Okay, he was taking training in some other city. So he said, you speak to him. I said, fine. So the brother spoke very nicely to me as a doctor. He was very, he is just a resident doctor. So, he was very nice. He said, no, ma'am, you please go ahead, do the surgery, put this lens. So we did everything as per their demand. Like they said, okay, you go for this accuracy of IQ. I said, okay, fine. Whatever you lens you already done, you have discussed with your colleagues, you have come to terms, ki, bhai, I want this discussion at this price. I said, okay, fine. So we did the surgery, madam. The patient is fine, totally, absolutely no complication. Now this journalist, one day he comes and he says, no, my mother needs specs. I said, okay, fine. This is monofocal lens. You will need specs. We gave her specs. So he says, no, but actually you said there will be no specs. And now that you are saying we need specs, that means your operation is failed. And I want the money back. So I said, see, in no way you are getting the money back. Your surgery is successful. This is part of the treatment and you are going to need glasses. So you wear glasses and go. This is 1 year back, madam. And since last 4 to 5 months, the fellow has been troubling me like anything. He has damaged my car 4-5 times. He has, he goes and meets the corporator. The corporator called me, madam, his mother's surgery has gone failed. I said, sir, you please bring the patient. You also come with him. You let me see the patient first. Okay, what is damaged? What is happening? We have gone to multiple doctors and multiple doctors have said that this is the wrong surgery. I said, okay, fine. Do you have the doctor's report? You want to come and discuss with me? Who is the doctor? No doctor writes it on the paper, but this is a wrong surgery. One day he says you have not done the surgery properly. One day he says you have put a wrong lens. Another day he says you have given wrong spectacles. Fourth time he says, there's multiple reasons he is going. You will not believe, madam, he has damaged my Mercedes 6 times. He has removed the logos. He made scratches on the car. He has done so many things. I can't believe. One day his lawyer called me up. So lawyer is supposed to be his friend. I said, are you his lawyer? If you want to discuss, you come here. Madam, he doesn't come. He doesn't discuss. He doesn't want to sit around. He is going on doing these things. He went and put some Google reviews. That is okay, acceptable. But then he goes on doing these things, doesn't want to discuss. Now, this is a real difficult situation wherein multiple times I have told him, you come over, you sit across. What is your concern? Bring the patient. We will take the patient to any doctor you want on this earth. I will come.
Have you taken any legal action?
I have not taken any legal action. I approached this thing. What advice was given to me that to approach a police station and file a complaint against him. Now, madam, what is the problem is I am a single lady practicing. I have my own small eye hospital setup. So here it's like, even though I'm here since last 25 years, what happens is, people just pick on these things, okay, this, and you see when they see the car, when they see these things, I don't know what is making him jealous. I don't know. There is absolutely no. If I had anything been wrong with his mother's, I would have been the first person to help him. He says, you have not taken the physician fitness. How can you operate? Now he raises these things 6, 7 months, 8 months, 10 months after the surgery. I think nothing happened to his mother.
Dr. Aparna, I think again we'll be going to, I know your case is very important and I'm sure you are facing a lot of trouble, genuine trouble because of this. And that requires actually conflict resolution between you and the patient party. And, there are mediation parties, mediators who help in resolving such cases. But taking legal action is one of the ways that can help you control the situation. If you are not taking any action, that is actually encouraging the other person to go on. And especially if they can see that you are not taking any action, that means either you are guilty or you are scared of law or you are not capable of taking any. I think that is one of the weakness, doctors have. They are too scared of the law, and sometimes that backfires. That backfires. Your civility is considered as, you being coward. So you really need to, consult a lawyer. One, notice from a senior lawyer in a language can set this person right.
Now what has happened is, madam, like the whatever the damage is done to the car and this and that I related earlier. I
So
was
do you
wondering
have
why
any
this is
evidence to
happening.
it? Do you have any evidence to it?
I don't have any evidence. That is the problem, madam. I don't have any evidence. I'm just guessing it. The way people are calling me and talking about one particular patient only, that makes me suspicious. I don't have any evidence. Another thing is, why don't I'm not involving the police?
Aparna, I think again we'll be going, out of the purview of the topic of discussion. Because I know your case is important and you want to, talk about it, but then we will not be able to cover the topic that I want to share with the participants, because I want them to know how to prevent such things from happening. We are focusing on how do you manage that situation. Of course, it has gone out of your hands and now you really need to take some action. Maybe we can talk one-on-one and, see what can work in your case. But right now, I think, I'm sorry, Dr. Neha, I will not be able to give you a chance to speak, and even to Mamta, because it's already 10 minutes to 9 and I need to complete the presentation because I want to share the protocol with all of you. And then, of course, we have those, presentations to be done by all of you. So I think this discussion has at least opened our mind to the idea that if we can handle it early on, I think we can manage to control the situation at the earliest. Do you agree with me on this? So if I may ask you, what are the common reasons why do patients become aggressive? Can you think of, and I want you to write in the chat box. What are the common reasons that patients become aggressive? So unfavorable, unexpected outcome, poor treatment outcome, unresolved complaints, if their patient condition is not getting better, incomplete information, improper information, patient not briefed about their disease status in timely manner, expectations are not fulfilled, disappointment, bad attitude of doctors or staff. So you're right, these are very common reasons. Adverse patient outcome, hospital bill beyond their expectation, hostile behavior of the hospital staff, rude behavior of the doctor, and when they don't want to pay, that's also there's a possibility that they may resort to becoming aggressive and trying to divert the attention and bargain with the hospital. And when the patients are making to move here and there, poor prognosis of the too high expectations, especially increases in case of poor prognosis. Death, yes, I agree with you, Dr. Manisha. Whenever there's a death, there's a reaction, aggressive reaction. So expenses, if the expenses are too high and they think that it is too much or they have been overcharged, ICU bills, yes, I agree. And then primary consultant not giving the visit, or they are not being attended by the consultant or being briefed by the consultant. How many of you could think of a medical condition that could lead to aggressive behavior from the patient party? Something like dementia, delirium, traumatic brain injury, neurological disorders. Can they also become a reason for patient becoming aggressive? I'm sure
Yes, ma'am. Yes, ma'am.
Also, certain mental health conditions, for example, schizophrenic patient or manic depressive patient, when they are in complete state of excitement and lack of insight, they at times act very, very aggressive. Even patients with personality disorders act very aggressive, can act very aggressive. Then substance use and substance withdrawal also can land the patient in aggressive behavior. I'm sure you must have seen patients who are under the under the withdrawal symptoms, who are deprived of the medicine or the drug that they are taking, they can act aggressive. Severe pain can be a reason for anybody becoming aggressive. Extreme pain can actually derail person's logical thinking and completely, make the person aggressive. Then certain environmental factors like overcrowding, noise, uncomfortable living condition, or the room is very hot, dirty, foul smelling, long stay. Yes, ICU psychosis, we all have read and we know patients become extremely aggressive if they are in a hospital or in ICU for longer than usual time. So these are also the reasons for patient becoming aggressive. It's not always that they are unhappy with us. They could have their own reasons to be aggressive. So we should know. Now, this case that happened in Kerala, where a young trainee doctor was stabbed by the patient to whom she was dressing. He stabbed her with the hospital some I think some surgical instrument. I think he picked up and he stabbed her.
Some scissors which were kept as part of the dress.
Scalpel.
Imagine. Now imagine, we can blame the patient, but if you look at the lapses at our end, we could have prevented this death. One, the moment patient comes into our premises, do we evaluate the patient? The other day I was discussing with my daughter. She is a dentist in USA. So I was discussing, I had happened to go to her clinic. Of course, US, we are nothing in comparison to them in terms of the setup and the arrangement. But when I was discussing with her that how do you manage when patients become aggressive, she said, do you know, mom, when the patient comes to our clinic, we start Dick's analysis. I said, that's very difficult. And how do you do it? You're not using any pen and paper. And how do you do it? Have you heard of the word DISC analysis? It's a personality analysis. DISC analysis. DISC is a test for the personality test. So I said, how do you do it? Do you use a paper and a pen and make the patient answer some question? She said, no. We have trained our staff. Anybody who will interact with the patient would do the DISC analysis and would make a small noting from his or her observation that this patient is probably personality A, personality B. So that means we know that this patient is likely to become aggressive or this patient is likely to become, behave. So I know we can't do that, but can we be mindful by observing the patient? And actually we can identify certain patients who are asking, picking on small things, or they have a lot of questions, or they want value for money and they, you can make out from their behavior, from their conduct, that this patient can create problem. Then just knowing is not enough. Then am I proactive in making sure that we reduce the number of irritants that happen between the patient and us? A lot of time we can see that this patient is very demanding. Do we really see that, okay, this patient should be handled carefully so that the patient can go back safely and we are also safe and the patient is also safe? Usually when the patient is, misbehaving, we get irritated. And we, in the heart of our heart, we say, I will not give you what you want. I will not provide you the services that I would otherwise provide to my patient because you are misbehaving, because you are rude, because you are disrespectful. That's the human mindset, how we have a tendency to give tit for tat. Whereas in healthcare, that's something not the right way. So these are a couple of things, but if you can identify right in the beginning, that this poor girl, young doctor who got killed in Kerala because of this patient, maybe that patient was mentally derailed. Maybe this person was under the influence of some drug. Maybe this person was under the influence of alcohol.
He was alcoholic.
And if I know that this patient is alcoholic, why will I send my doctor to go and attend that patient? I will not even send my male doctor to do that. And if I need to do, then there should be enough number of people to make sure that in case if this patient misbehaves, I should be in position to control the patient physically. That is where I need to have.
Can we restrain these patients? Because it's even people that, I mean, we can't escape dressing these people, ma'am.
We
Many
cannot,
casualty
we
people
cannot
come with,
attack. Sneha, we cannot attack, but we can restrain.
not attack, restrain. I mean,
It
restrain
is
and
allowed.
enhance.
It is allowed. It is allowed.
But we need to take consent, isn't it?
If there is no attendant, then where is the consent? No. See, whatever it is, even if it is not a healthcare situation, self-defense is always, accepted. As I said, we don't have to hit back the patient. We don't have to assault the patient, but you can definitely restrain the patient, because that you are doing to safeguard yourself and your other, but that requires presence of mind. So see how we missed. And if you have heard of that, what is that? A cheese model. What is that cheese model?
Swiss cheese model.
Swiss cheese model. Do others know? Do everybody know? So Swiss cheese model is,
No.
yeah. So let me explain you in a very simple, brief manner. That says, when every checkpoint fails to perform its duty, that is where the error will happen. So this incident of this poor girl dying at the hands of this, patient, I'm sure there could have been number of checkpoints where we could have actually prevented this. The moment he entered, the guard saw the patient is drunk, reporting to the doctor that this patient is drunk, we need to be vigilant. The nurse who attended the patient, if she saw that patient is alcoholic or is drunk and is not in his senses, there could have been a reporting and there could have been action. Then the doctor who was attending, if she could sense that this patient is drunk and is not in his senses, she could have refused that I'm not going to attend this patient alone. There has to be security. There has to be people who can help me handle it. I mean, we have to learn to voice our safety. But when everything failed, we lost. I think more than the patient, we should be taking the responsibility in failing to do our duty. And if we had created those checkpoints, and if those checkpoints are working, we could have prevented this such a big mishap from happening. So that was just to help you understand that it is not always something from outside that can make the patient aggressive. It could be the intrinsic factor also. So we should be mindful of that also and should be able to identify that. So let me quickly share the presentation with you and take the discussion further from here. And I wish to share the protocol with you so that you know how we have to go ahead and handling the situation. There are some answers in the chat box. Let me quickly have a look at it. Okay. Sneha, it is Swiss cheese. Can somebody write in the chat box if you know the spelling?
I meant the one used by your daughter.
Oh, disc.
Your daughter in
yeah.
US.
I will write. Disc analysis. Yeah. Santoshi has already written. Yeah. Thank you. Yeah. Hallucination. Yes, Dr. Priya, I agree. And psychiatric patients, definitely. So I think now at least we know that this also can be a reason for patient becoming, aggressive or violent. So we are going to talk about how do you really, identify such situations and also handle them and control as early as possible. So we normally talk about medical triaging, which we all are familiar with, that, okay, this patient is critically ill, so should be attended first. I think we really need to learn social triaging. So this is the term given by me. I have not seen it on the, web anywhere. So I think this is the term that I coined, that we have to learn to identify patients who can create problem. So it is not just the patient, it is the patient party in total that I'm talking about. And if I can sense that this patient can become aggressive, I should remember that I have to handle this patient with care. Crisis moments don't happen suddenly. There's always a storm before it rains. But we ignore these warning signs. We overlook these warning signs. And that is where we actually land up into a major problem. So it gives us an opportunity to intervene before the crisis happens But do we really notice these red flags? Do we really attend to these red flags? That's a $1 million question. So understanding why do patients get angry will help us know what all can be done to prevent this aggressive reaction. So I came across this concept offered by Mark Berkeley. He says there are 4 phases of anger that start from I. So they could be one of the reasons for patient party or anybody becoming angry or aggressive. For example, someone when has a palpable sense of injustice or a sense of injury or a sense of invasion, there's all possibility that this patient will have the intention to become angry. So let me explain these 4 terms briefly to help you understand how all this can end up into aggressive reaction. For example, the first angry I is injustice. When the patient or the attendant feel that they are a victim of an injustice or unfair treatment or disloyalty, they are likely to feel anger. They are likely to feel aggressive. So there are studies that actually have shown that patients have reported unfair treatment in the hospital setup. For example, this study published in Indian Journal of Medical Ethics in 2018, it surveyed 1,431 patients across 6 public hospitals, and they found 20% of the patients reported experiencing some form of unfair treatment. So 1/5 of the patients are more likely to be aggressive than others. In another study done in the Tamil Nadu hospitals, it surveyed around 1,000 patients and found out 26% of the patients reported injustice, such like adequate or disrespectful treatment. In another study in 2020, 800 patients were surveyed in 5 public hospitals in Mumbai. Again, around 30% of the patients reported experiencing some form of mistreatment, such as verbal abuse or neglect by healthcare providers. So when something like this happens, it doesn't actually immediately boils down to aggressive reaction. But this can be one small irritant. Later on, when they have a chance, they can become aggressive as a result of it. The second I is injury. So whenever the patient experiences some harm at the hands of healthcare provider. So if you look at the first picture, a lot of time in labor room, in ICU, when we, or even in the OT, when we give patients some clothes to wear and the clothes are actually not appropriately covering the patient, or there is small hole, or there is not enough, tying material and some part of the body is, being exposed. They may not voice, they may not say anything, but there is definitely a feeling that my physical, safety or my body is not protected. So things like this, or for example, when we restrain the patient, the family feels that this restraint has been just to, control the patient. So they feel that the patient's rights have been disrespected, or anywhere if they feel that they are generally disrespected by us, discarded or ignored, or in case if they experience any kind of physical harm, there will definitely be anger. Even where the patient has experienced fall because of our carelessness or neglect in the bathroom or from the bed. How much ever explanation you give them, they will never be satisfied. They will say it's your duty to make sure that the patient is safe. We have handed over our patient to you, and how can patient fall when all of you are on duty? So no amount of explanation will help. So these kind of incidences, for example, patient having pressure sores while being in the hospital, again, they're going to be very annoyed with us that we haven't done enough to prevent pressure sores. So incidences like this can definitely make the patient feel that we have not taken good care, and there will definitely be a sense of anger against us. Again, couple of studies that help us see patients, how they feel that they have been injured. In a study where they studied around almost like 33,000 patients, they found that most common type of harm that the patient experiences is falls, pressure sores, and medication error. Now, you may say this is part of hospitalization. Patient party would not accept it. For them, it's a harm done by us, So we are responsible for it, and their anguish against us is very justified. In another study, almost like 42% of the patients reported experiencing at least one adverse event during their hospitalization. It could be like psychological harm, which could lead to further depression or anxiety, or it could be any physical harm like injury, fall, or medication error. In another study, 237 adverse events were studied, and it was found that most common harm to the patient is around medication error, falls, and pressure. So again, when something like this happens, patient and patient family will have anger against us. They may not immediately start fighting with you, but one above the other, when these things, start piling up, it can ultimately end up into aggressive reaction. The third angry eye is invasion. When patients feel that their freedom, their privacy, their autonomy is constricted or disrupted or violated, they are likely to feel that we are invading in their place. So, although the cameras that we hold is for the patient's safety and for everybody's safety, but for them it's something like we are intruding into their, privacy. And sometimes also, when their identity or the bodily or psychological integrity is threatened, they are likely to experience aggression and anger against us. So, and in a study, they found out that privacy and dignity during childbirth, and I think this is nothing new. I mean, those of you who are practicing gynecology, you would agree with me, and we have all seen it. Usually in labor room, we actually ill-treat the patient. We literally hit the patient very badly, or although we say that is to actually help the patient push the baby out or to help the patient deliver faster. But very honestly, if I ask you, we all know labor pain is considered almost equal to MI pain. I think sometimes we even say the first pain is MI and the second pain is labor pain. And sometimes we reverse the order. Labor pain is the first pain and the MI pain is the second pain. My question to you is, do we ever hit the patient who is suffering with MI? No. Then why do we hit this patient? Why do we make fun of them? We pass very ridiculous comment talking about their pregnancy or their conception or their number of children and whatnot. So patients have reported that they feel that their privacy was violated and they did not. I have personally seen one of my relative being delivered at one of my friends' big hospital. There were technicians or anesthetists, doctors moving around. And this patient, after delivery, her sheet was removed because it was soiled with blood, and she was lying naked on the table. I mean, after everything was over, I did talk to the doctor and I said, that's not done. If you're removing the sheet, you have to immediately cover the patient with another clean sheet. You can't, put the patient naked on the OT table and wait for the next sheet to come. So I have personally seen this, so I'm not surprised with the findings of these results. In another study, in psychiatric consultation, patients felt that they were stigmatized and discriminated because of their mental health condition. And they felt lack of privacy and confidentiality during their consultation. So these are all invasions. See, talking about your medical condition, talking about your illness is not easy. It's not, very comfortable arrangement. And that too, when you have unnecessary people around you. Patients who have, gone through abuse or who have been raped, we have seen all hospital staff will come and see the patient one by one as though she is an object of, exhibition. And what will happen if you are able to look at the face or the body of that patient? But we have seen hospital staff invading. Forget about this. A recent incident where Lataji was admitted in a hospital. I'm sure you all must have seen her video. She appeared so fragile, so sick that it was very heartening to see her physical health condition. And imagine our healthcare providers were trying to capture a picture with her, a selfie, or making a video of her health condition that's happening. What is this? Isn't this invasion? Isn't this disrespect? So when all these three things happen to the patient, the last I is intention. Because when enough is enough and the patient feels I can't handle it anymore, and there is enough energy to actually take an action and there's a determination to do something, that is where the patient is likely to act out. So imagine all this has happened in the background. Nobody has noticed, nobody has addressed, nobody has bothered to, know. Now already there's accumulated anger and patient is ready reflexively or purposefully to challenge the status. And that is where the patients start acting out. So let's understand what are the four stages actually. And actually, before the actual acting out stage comes in, there are two points where you can control the situation. The first one is anxiety, when you can see there is some increased anxiety which can be managed. Then there will be a second stage which is called defensive stage, where the patient or the patient party is acting, is kind of voicing their concern. At these two stages, we can definitely intervene and de-escalate. But if we haven't done enough in these two stages, be ready for the third and the fourth stage. So what are these stages? Let's understand and see what we can do in our capacity. So crisis stage one is anxiety stage, where you can see an observable and unusual change or increase in the behavior. So can you tell me what changes do you think you will observe in this kind of in this stage of crisis? Can you write in the chat box? What changes will you see in the patient in the initial stage when the patient is actually, patient or patient party is becoming, anxious? Yes, they start talking loudly. I agree with you, Payal. Multiple queries being asked. Yes, they are restless. They are talking loud. Yes, Dr. Kundan, I agree. Yes, you can observe restlessness. They are pacing up and down. I agree with you, Sneha. Very right. So see, they are fidgety. They are talking very fast. They are asking a lot of questions. Yes, Dr. Ambed. Videos are circulated. If they have already captured the video, yes, they are. They may be even talking about it. Too much illogical question. Aditi, no question is illogical. Maybe we are not able to understand from where it is coming, but trust me, there is always a reason for that illogical question. Asking for change of a doctor. Yes, when they say like this, that means they have lost trust in us. Picking up on small things. Yes. So that shows that now they're getting frustrated or upset with breathlessness, or they want someone to address them. Yes. Asking for discharge. Yeah, that's also possible. Asking the same question again and again means anxiety. Yes. So very right. I think you have pointed out to some of the very pertinent behavioral changes that you will be able to see. So usually when patients give this behavior, we start becoming angry. So we all react. Okay, let me first cover this and then I'll talk about how we respond normally. So in this stage, you will see, as you have already mentioned, I think most of the things you have already covered, that they will either, start speaking in louder than normal voice, or even their speed of talking can be faster than normal. They may be pacing up and down. They will try to talk to different people. They will also try to bring in their name. I know that doctor, I know that administrator, I know that corporator. So they'll try to, pull their strings to show you that, I mean, you need to be more. Or they may have an expression of doubt. They are not satisfied, or they want to change the doctor. They want to go for a second opinion. As very rightly said by you, asking a number of questions, like Aditi said, illogical questions. So I'm not sure how many times the questions are illogical. Maybe we are not prepared to handle those questions. Maybe we don't expect the patient to ask that question. But I somehow feel that questions are not illogical. They are not, maybe they haven't asked it in the right way, but usually these questions are not illogical. Now, normally, how do we handle? See, we experience four kind of situations, emotions in such situation. For example, somebody is not behaving well or is speaking in a louder than normal voice. I'm a nurse on duty, or I'm the front desk staff, or I'm the resident on duty. I can see this patient attendant is, pacing up and down, or is speaking louder, or is talking to somebody on phone and saying, "Aap aa jao, jaldi aa jao. I'm not happy. You need to come here as soon as possible." So you can sense that there is some amount of restlessness. One emotion that we all experience, not all, some of us might experience, that is we don't pay any attention. And what is that emotion called? What is that emotion called? When you don't pay any attention, when you don't acknowledge your emotions.
Ignore.
Okay, ignore. In terms of emotional reaction, it is called apathy.
Apathy.
Apathy. When I'm not acknowledging, when I'm not, indifference, absolutely. When you ignore or when you are indifferent, you're not even taking, a notice of that. So that is apathy. Or if the patient comes and starts arguing with me, I'm a nurse on duty or front desk staff on duty or resident on duty, and they start arguing with me. Abhi aake dekhiye, please come and see quickly. The patient is in pain. Why are you not attending? You need to come just now. Please get up and come immediately. The second emotion that I might experience is called antipathy. And what is that antipathy? What is that antipathy?
Feeling anger towards them, or feeling like doing something against them.
And deliberately not cooperating. Doing something against the patient. So, okay, I'll come in 5 minutes. I have to attend the patient. Or I will go out to have a cup of tea and then come back and attend. Or I will not go and talk to the patient. So that means doing something which is against what the patient wants. That is antipathy. The third emotion that we can experience, if you see somebody crying and you start crying with them, and you also feel bad about the patient and feel bad about the situation, that is called sympathy. So you are pitying the patient or the family. Bichara. Very sad. And that is called sympathy. Whereas the actual emotional response that we all need to, mindfully inculcate in our psyche is empathy. Thank you, Dr. Amrit, for writing empathy. If you can look at the situation, in AIMS Trauma Center, a young girl was brought, young child. She was playing on the rooftop. While playing, unfortunately, she fell off the rooftop. So you can well imagine if anything like this happens in a locality, how would people gather and how will they rush with the child to the hospital? Even those who are not connected will definitely, come with the child to the hospital, and everybody will be curious to know how is the child, how is it happening. So this girl was brought to the trauma center, and as usual, the child was taken in and all attendants were made to wait outside. But the guard's behavior was very rude with the patients. They wanted to go in. Guard was very aggressive. He did not let anybody go in. In a few minutes, the girl died. The family or whoever was there, they literally, broke everything that was possible if they could bear that. I'm not endorsing the violent behavior. I'm trying to take your attention to the point. Had the guard talked to the patient's family in a more responsible manner, saying that I know you want to see your patient, but please allow them to work on your patient. Once your child is slightly settled, then we can allow you to go. It could have been done by a doctor, it could have been done by the nurse, it could have been done by the anybody who is there in it. But unfortunately, it's more like diffusion of responsibility. Nobody thinks that that communication has to be done with the family. So I was asking a doctor who was casualty in charge, emergency department in charge. I said, how do you manage when patients come, when attendants come, a lot of attendants come with the patient. So she said that I normally will take the patient in and then I'll tell the family, see, give me time to manage your patient. I want all of you to wait outside. Once the patient is settled, I will come personally and talk to you and explain you about the patient's condition. So all of you, please stay out, sit at one place. The moment we are in a position to update you, I will call you personally and talk to you. So, she said, never I have experienced any violence, because after we settle the patient and when I can see my patient is now in the right hands and the treatment is on, then I will say, okay, attendants who are very close to the patient, maybe children or parents or spouse, they can come and talk to me, and whatever questions you have, I'm ready to. So what I'm trying to say, the moment you see any aggressive reaction, these red flags, and if you know that this case needs to be handled, this situation needs to be handled, actually you can prevent any aggressive reaction and control it right there. So I can see some more answers here. Also, that in talking to you, now I will be loose on patient. Yes. Yeah. If you tell the patient that right now, I think the primary focus is the child or is the patient. So let me, go and look after the patient rather than talking to you. I think that's also one. So whenever you see these red flags, don't ignore. Please attend to them. That is the time where you need to, first of all, segregate them from the crowd. So give them a safe place to express. Now, Dr. Sneha, like you were saying, that we normally do it bedside. I know the practice in most of the government hospitals that we start discussing at bedside. One, when you're doing it at bedside, neither the attendant is comfortable, nor you are comfortable. Plus, you are having all the discussion in the presence of patient. Maybe you would like to inform the patient later. Although if I go by the book, it is the patient who should know about their condition first. But we all know it is usually the family who needs to know so that they can, share the information in a staggered manner with the patient, because we don't know how the patient might react. So it should always be done, in a safe place. Make them sit, segregate them from crowd, make them sit and talk, offer them a glass of water. This we had discussed last time also. It's very important to identify yourself, who you are, how you're going to help, explain the procedure, process, acknowledge their pain. I'm not going to spend much time on it because we have discussed this last time also. So empathize and then anticipate their questions and know how you are going to handle those questions. Now, when they're speaking, identify the reason, because they will definitely, sometimes patient isn't disclose the disease he's suffering from. Yeah. See, although if we talk about the patient's rights, we have to seek patient's permission. Whom do you want me to share the information? So one of the ways to respect this, law, or to, ensure that we follow the patient's right, is to seek permission from the patient. So in case if I need to talk about your disease, do you want me to come to you and talk to you, or whom do you want me to talk to? So the patient beforehand can give their consent to share the information, maybe with parents or with any close family member, whomever they want to, especially things like cancer or some irreversible condition. So when you talk to them and when you try to identify the reason, if you listen to them properly, I think they at least start having this feeling that, okay, somebody is ready to understand their problem. Most of this situation can be diffused or can be handled if you actually let them in ear, when you actually listen to them. So when I say listen to them, it has to be done genuinely and not like, okay, whatever you are saying, I'm listening, but I'm not paying you much attention. So there may be a need to ask questions. There may be a need to restate whatever the patient has said or rephrase whatever the patient has said to make sure that what you are hearing is what the patient wants to say. When they're sharing their concern, mind your demeanor. In case if your expression says, I don't care, your problem is very minor, why are you making a fuss of it? There is no reason to be aggressive about it. I don't have time for your silly questions, or your question is nonsense. You're asking an illogical question. I may not verbally say, but my demeanor might actually indicate that. So all that is not going to be of any help. Don't interrupt, don't try to correct them. Even if their information is wrong, note down that you need to correct this information, but don't try to say, no, 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 what you're saying is wrong. That's not the reality. I think you're mistaken here. That's not the story. My staff told me that you are lying. So when you say things like this, they are going to further get aggressive. So don't be in a hurry to justify yourself or your staff member, and don't try to shun away their concern when they come up to you with your problem. So empathy, I think we have talked enough. Repeatedly, I'm saying, put yourself in their stage and think, if you were there and it was your family member, how would you, feel? So don't try to judge or discount their feeling, whether you think their feelings are justified or not, but those feelings are real for them. So you have to acknowledge that, yes, I understand what you are going. So when you acknowledge their feeling, they start having this faith that, okay, there is somebody who can read my emotion. There is, there is somebody who is ready to, understand my plight or my situation. Apologize. Again, like last time we discussed, the apology is not like taking responsibility, but apology is for the inconvenience the patient is gone through. So I think I shared this case with you last time also. A relative of mine who is an NRI who came to India for a vacation. Unfortunately, he had cardiac episode. He had to undergo angioplasty. He went for angiography, and immediately the doctor did angioplasty for him. And then after he came back, it's one of the premier hospital, very well-known hospital. I will not name the hospital. So this patient came back to the bed after the procedure, and then he requested for urinal. He said, I want to use, use urinal. So the attendant on duty, then he said he'll provide. It took good 5-10 minutes to give him that urinal. Ultimately, the urinal was provided. And after handing over the urinal, the attendant went away. But this patient was holding his urinal and urinating. And because his bladder was too full, and we know in angioplasty, we give a lot of, IV fluids simultaneously. So his bladder was too full that the urinal actually got completely filled, and then the urine started, spilling over the bed. Now his bed sheet, his mattress, everything was, full of urine. He called the attendant, he handed over the urinal, but the bed was wet. So by then I had also reached with my husband. So I saw that the bed sheet was completely wet. I went and requested the nurse, that, sister, can you please get the bed sheet changed? Now imagine, now to somebody it might appear a very small thing, but can you believe it took me almost 30 to 45 minutes to get the bed sheet changed. I literally had to finally go to the resident who was there, requesting him that, can you please ask somebody to change the sheet? Again, to somebody it might appear a very small issue, nothing very big deal. But imagine yourself lying on a sheet wet with urine. So in that situation, if I'm on duty and if I apologize for the inconvenience and if I correct the situation, I think the situation can be managed. But usually we don't like to apologize for something like this. We think that's the part of patient care, and that's how the patient care happens. So the meaning of word sorry here is not just to taking responsibility, but it could also be expression of compassion. Or when you want to actually, when you see that, yes, something wrong has been done by my staff, for example, wrong medicine, wrong injection, or not giving medicine on time, or not giving medicine at all. So that's something definitely is an error, and we need to take responsibility for the wrong done to them. And again, apology does help. How the apology fails? When you say, oh, if you're saying what you're saying is true, then I think, yes, I agree with you. Or when you say there was a mistake, but actually no harm happened to your patient. Or when you say, I'm sorry, we cannot attend to individual requests. So this is something very common. So you'll have to bear with me. Or when you say, I'm sorry, we don't allow visitors during non-visiting hours. So you will have to wait for your turn to come. And this is the patient attendant who has come from a different place and is just waiting to see the patient. Now, when you make such apologies, it actually do not help in any. I think at this point, trying reverse empathy would help. As I said, help them see your perspective. A lot of time, they are not able to see your point of view. So if you help them see, for example, for discharge, somebody might come and start arguing with you. The consultant said discharge at 10 o'clock and it's already 2 in the afternoon and you have not given me discharge. But if I can spend 2 minutes and help them explain that discharge does not mean just verbally saying discharge. There's a proper procedure that we have to follow. We have to actually have clearance from these departments before we can discharge you. Or we need to get clearance from the TPA before actually we can release you. So when you help them see your point of view, then probably they will understand that you aren't doing it to trouble them, but you are doing it to help them. So explore alternatives, check what the patient want. A lot of time, what they want is very small, which you can easily do. The idea is sincerely try to resolve the issue and address their concern. Focus on the solution rather than, on the behavior, because behavior will be aggressive, and then avoid being defensive. Because a lot of time when we act defensive, there's a possibility that can become. So we have done this activity last time. So now you know that if you go out of the box and try to find a solution, maybe you will be able to find a solution that can, bring down the patient's aggression and aggressive reaction, calm down. Again, that's another possible way to connect those 9 dots. And did we see a slide where we can connect all 9 dots with 3 straight lines? We have done that also. So now you know that there are so many options to handle this situation. So you have to really go out of the box to find solution to the problem. The second crisis stage is called defensive stage. So if you haven't been able to handle the first stage, or maybe the first stage is noticed and handled by the front desk staff. Maybe it is the nursing officer who is in the indoor, or it could be the front desk staff in the OPD, or the floor manager in the indoor. So if that has not been managed well, chances are the patient will go to the second stage. So this stage is called defensive stage. You will see there is increased emotionality. Patient will lose rationality. No logic will work here. And they are more likely to act, at least verbally, they will appear very aggressive. You can see that their body language and their verbal communication will be aggressive. So slowly now their rational mind is being hijacked by their emotional mind. So here you will see that they will either start becoming belligerent, or they may challenge you or your authority, or you may even accuse you of being irresponsible and not taking care and being negligent. So I mean, most of it will be more like not making sense, but that's out of anger that they are shouting. So again, you will see them speaking in a loud voice. You can see them arguing with the security staff, technicians, and nursing staff. They will express their dissatisfaction. They may disagree with what others are saying or what others are offering. They may even refuse to cooperate. If you say, okay, let me speak to somebody, and they'll say, no, no, no. Or if you say, okay, please sit down and talk to me, they'll say, no, no, I don't want to sit down. I'll stand and talk to you. So they will refuse to cooperate or listen to you or anything. So even when you ask them to, make payment, they will say, I will not make any payment. You first get the things done, then I will make the payment. So, now they are kind of, becoming aggressive now. They are moving towards. So at this stage, our response should be to first of all provide guidance. So here, when you help them see, I can see you are angry, but that's not going to help us to resolve the issue. So it's better if you calm down and talk to me properly. You tell me what are your concerns. I am ready to help you. I will try my best to see what can be done. But for that, you need to really calm down and talk to me properly. If you are angry and shouting like this, I will not be able to help you. Staff will not be able to cooperate with you. So what you are doing, you are providing guidance to them about their behavior. You could also be directive in your approach. So where you are very clearly saying in a very firm way that this is acceptable or this is not acceptable. So for example, if you say, see, if you really are not satisfied, I think I would ask you to go and meet the, PRO or whoever is the person responsible for managing that situation. You can actually go and write your complaint. Then definitely somebody from the department will, take an appropriate action. You could even ask them to go and give their feedback if you think that is what you want them to do. Or if there's a person who is responsible for managing that situation, you can direct this patient to go and speak to that person so that their problem can be resolved. The third response that you can take is if you think you are the only one who has to take charge of the situation, then take control of the escalating situation. Don't avoid it, address it. So the approach has to be problem solving, because if you are going to take, control of the situation with the idea of resolve the problem, you will definitely be able to find a solution. Another action or rather response that will help is clearly actually communicating what you can do and what they should do. Set boundaries clearly. For example, if they're shouting in the ICU, telling them clearly that, see, this is not the place for you to shout. There are other patients and we can't allow you to talk at this, volume. So if you have some concern, let's sit and talk in the counseling room, or whatever way you want to kind of set boundaries, make it very clear what is acceptable and what is not acceptable. Again, please be firm but not aggressive, because if you will act aggressive, they are likely to become more aggressive with you. So at this point, I think it's very important to be aware of your body position. So standing eye to eye, toe to toe with the person sends a challenging message. So I'm sure you will not do it, but in case if you have called your security in, and if one of your security officer goes very close to the patient party and stands very close to them and, kind of tries to threaten, there is a possibility that either of them can start hitting each other. It could be either your security staff or it could be the patient, because when you invade somebody's personal space, it can increase individual anxiety and can lead to acting out behavior. So like we were discussing, have security, stand by, let them not be individual field. As long as you think things are okay, you can manage, they are talking normally, they are not acting aggressive, you can manage. The moment you feel there's a possibility of, for example, if they're hitting on the table or if they're coming closer to you, that's an indication that this person can hit me or can physically, harm me. That is where you need to have the security come in. But please remember, if the security person comes very close and stands eye to eye and tries to threaten, this itself can, aggravate the situation, and there can be a retaliatory, acting out from them. So keeping safe distance, more like a 3 feet distance, is a good idea. I would say have a table in between you and the patient part when you are sitting, and preferably slightly larger table, so that even if they want to, physically catch hold of the person who is attending, you can manage. And then, as I said earlier, also follow two-door policy. So if you have a, gate behind you that you can use to get out of that place, that's the best way to safeguard your. So at this situation, I think we have to remember, arguing will not help. Don't get into argument, because if you answer for the sake of answering, especially sometimes they will ask you questions just to provoke you. So do not answer all questions. Do not try to answer everything, because that's not going to take you anywhere. A lot of time, redirecting their attention to the patient's welfare will help you control the situation. So when you say, see, I can understand you are angry, but at this minute, I think patient welfare is important. If you remember in the last discussion, Dr. Manisha had mentioned about, the mother who was very aggressive and who was not letting anybody touch her child because the child was pricked 2-3 times to, start IV or to give medication, and she became very furious and she literally slapped the nurse or the doctor. So Dr. Manisha did make a mention that I said it's okay if you want to take the patient to another hospital, or if you don't want the patient to be treated by us, that's perfectly all right. But right now the patient has to receive medicine. So we have to make sure that the patient gets the medicine on time. So what she did, she took the attention to the patient's welfare. So that's how somehow also you are able to calm the other person. So answering their challenging questions actually would result in power struggle. They may actually blame you, they may talk ill about your organization. All those things actually you need to, ignore. Dr. Amrit also have written in her answer, pride should be kept at bay. Yes, I think I know somebody might say it's easy said than done, but then if you have learned this, you will actually see that you can, handle this situation in a more effective manner. Dr. Amrit has also written, why don't hospitals put some notices explaining the long discharge process? I completely agree. I think that's one of the ways to inform. So which 2 slides, Dr. Amrit, do you want me to explain?
Ma'am, it's okay now. I'll see the recording and see them. It's
Okay.
fine. We have come a long way.
I didn't see your message.
No problem, ma'am.
So a lot of time, they just want to talk. They want to vent their feelings. It's actually all right to allow them to vent, as long as it is not harming anybody. Usually when they're able to vent verbally, you will see them calming down. But if you think you cannot allow them, for example, if it is ICU or OT or labor room, or it is ward and there are other patients and you think that's not the place, probably you will have to direct them and say that this is something not advisable here. If you have something to say, let's either go and meet the right person or, talk to the right, or go to another place and do it. So when they are, when they are still in the process of arguing with you, of course, you have to set the reinforceable limit, a reasonable limit to help them see what is allowed and what is not allowed. I'm so sorry. I'm having slip of tongue. Okay. So you can give them choices, what is doable and what will be the consequences. For example, if the person becomes very aggressive or belligerent or disruptive, you have to state limits. See, this behavior is not appropriate. If you are abusing the staff, or if you are, physically you're threatening me, again, this is something not, as per the law. So if you think, and then you are setting the limit or you're offering the choices and the consequences of acting out to the individual, if you see that the patient is not understanding, so I think you can imagine that the patient is now moving towards acting out. So at that stage, if you say, if you hit me, I'm going to hit you back, or if you hit me, I'm going to call police to you. So such things should not be, used to threaten, because that's going to further aggravate the situation. Your facial expressions, you have to really keep neutral, because when the person is angry, he or she is less likely to listen to what you are saying. They're observing your, facial expressions and your body language. So more the individual loses control, less they are likely to listen to your word, and their attention will be actually on your non-verbal. So if your expressions are calm, then they are going to, saying that, you are not, angry. But if you have gestures of anger or aggression, that's further going to aggravate the situation and they might react. So certain expressions like, I don't care, I can't do anything, what can I do? That's not my job. That's going to further aggravate the situation. Also, please avoid overreacting. Sometimes we overreact to the situation and spoil the situation. Only one person that you can control is you. It's again a mindful process. We have to learn to remain calm, rational, and professional in this situation. Usually, it's after the situation we repent. We repent that I shouldn't have said this, or I should not have done this. But actually, in this situation, we have to mindfully learn to control our behavior. So remember, your behavior is going to affect the other person's behavior. So rather than overreacting, use assertion. So sometimes tit for tat also is not a good idea. If the person is shouting, you also start shouting. If you ban the door, if you throw patient's file, or if you call security without any provocation, you are more likely to fall for fraud. So all through this while, keep a check on your own feelings. How are you feeling? What are you experiencing? So in case if you are feeling anxious, if you are feeling that I am going to lose my control, it's always good to let someone else handle it if you think you are not able to handle that. If till this point you think things are not in control and nothing is working out, there's all possibility that this patient can go into stage 3, and that is acting out. That is where the person has lost control of their behavior and can start hitting or throwing things, damaging furniture, even hitting people around. And usually they are not able to, they're not capable of reasoning at this point. So this is one point where any amount of discussion, explanation, calming down would actually make no impact. So I think your response, or rather our response, should be to push the emergency button and ensure safety of yourself and your staff member. So as I said, if you have 2 doors, tell them that, okay, let me speak to my senior and come back to you. Or let me ask my senior to speak to you. So the idea is that you have to ensure your safety. Activate whatever the emergency procedures that you have. Normally we call it code. Violate. Am I right? So you will have to, initiate that code so that you can get the required help from the right people. Once everything is over, the 4th and the last stage is tension reduction. That is where, when the emotions have calmed down, the person might gain some rationality, may also regret his action, and they may want to apologize or compromise. Especially if you have called in police, if they have been controlled or stopped by security guard, and police also is in your favor, that's where they will feel, okay, I think better than, rather than facing the consequences, let me apologize. Or maybe patient's welfare could be the reason where they want to apologize and they want to request you to continue the treatment. I know at this stage they actually want to make amends. And it's easier said than done. But this is an opportunity to make a positive change, reconnection, and resolving the issue. Usually, the situation is very upsetting for anybody who has gone through it. But then, if you can, you can communicate with the person as they calm down and move further, whatever you want to do. If you want to send the patient to another hospital, you have all the right to refuse. If you don't want to attend the patient, you can always say that I will not be attending the patient, because these are our rights also. But then mostly after they have done, they want to make amends and apologize for that. So these are the 4 stages. I think in stage 4, there's hardly anything much for us to do. But up to stage 2, we can definitely, we can train our staff to handle. Stage 3 can be handled by people who are experienced and are in good position and who know how to really handle emotions without being too reactive to the situation. In stage 4, I think is primarily the safety part. So you have to make sure that you are safe and your team members are safe. So when everything is over, it's time to document. Please don't forget to document the incident in the reporting format. So whatever the name of the aggressive patient party and the hospital staff who were initially to handle the situation, what was the background, how you responded, or the steps that you take to mitigate the situation, what was the outcome, and then what did both parties ultimately agree to, what aggravated the situation, or any suggestions that you want to give about the situation or solution for future implementation. You can make a mention. Kappa is a tool that I normally say that would help in managing such situations, because then we can reduce the number of such episodes if we apply CAPA in a very regular manner. And then also make sure that you write your name and ways that they can reach out to you in case if they need to discuss that. So after the situation is over, it's a good idea to sit and reflect, because that is where the real learning lies. When we are in a situation, we are not able to think very calmly. So if you sit back and do your self-check-in, discuss with your colleagues, read material, and then also learn how to handle crisis. So that will give you new ideas on how you can go about handling this situation. So this is in nutshell about the the protocol that I thought will help us in understanding how each and every staff member should know what are the different reasons for patient becoming angry. So where we can actually, make sure that we can reduce the number of irritants. And once the process has already begun or the crisis has already begun, how can we de-escalate or minimize the damage? Any questions about it? So a lot of crisis management depends on our way of handling conflicts. All of us have, a very set way of handling conflict. I sent you the questionnaire. So have you been able to identify your crisis management style?
Yes, madam.
So the lowest score is your crisis management style. And the second lowest is the backup plan. So if I may ask you to write what is your primary conflict resolution style and write your second backup plan in the chat box, that will be really good. Okay, Dr. Amrit has written collaboration. And what is the second option for you, Dr. Amrit? In case if collaboration does not work for you, what do you think you're likely to try? Okay, accommodating and collaborating.
Ma'am, collaborative and compromising both came out to accommodating and compromising both came out 7.
Okay.
That is the equal score.
Okay,
Equal score.
and compromising.
And compromising, yeah.
Okay, Dr. Neha also says, Dr. Neha, what is your second backup conflict resolution style?
Accommodative teddy bear. That is the one.
Okay. So Dr. Kundan has written collaborative and accommodative. Dr. Neha has written second as accommodative. What about others? Dr. Manisha, Payal, Aditi, Dr. Priya.
I haven't done my questionnaire, ma'am. I'm doing it right now.
Okay, so maybe I will quickly explain you the pros and cons of each style, so that you know what style should be chosen in what situation. Mamta, did you do that questionnaire or no?
Yes, ma'am, I have done that.
And what is your primary conflict resolution style? Have you?
I didn't, I mean, whatever the questions I gave, grading across that, ma'am.
You didn't do the calculation. It was a very simple calculation.
I have the...
No, but then write in the chat box, what is your primary?
Okay,
with the lowest score. Style with the lowest score is your primary style of conflict resolution.
I understand, ma'am. So I thought of asking you. So those 2 lines I left empty.
The answers you left empty or the calculation?
The last calculation, ma'am.
So Payal, yours is interesting.
I didn't understand that. But I have scores in my hand.
No, but if you have not answered, then what
second lowest,
Yes, Payal, go ahead.
I score both the competitive and accommodative. I don't know how.
Aditi, yours is accommodating and collaborating. Okay. Dr. Aparna, are you there? Santoshi, what is your?
Yes.
Dr. Priya? Dr. Priya, are you there?
Ma'am, yes, ma'am, I'm here.
So have you taken this questionnaire? Have you done your questionnaire?
Ma'am, I've done the questionnaire. The lowest I have is the competitive mode. The second lowest is the avoidance. Then compromising, and highest I got for accommodative. The second highest was collaborative.
So which scores are important, the highest or the lowest?
Both are equally important, probably like how you mentioned, maybe in conflict resolution, the lowest score.
And the
And-
second lowest is your backup plan.
Ma'am?
Second lowest is, like you said, your lowest is competitive. And second is avoidance. Am I right?
Yes. Lowest second is avoidance.
So I'm sure you would like to understand what exactly we mean by this, and also what are the pros and cons of these styles. So let me quickly share at least those 4-5 slides that will help us understand, the conflict resolution style. And one second. So by the time it is loading, I must inform you that the last session that is planned for 21st will have to be on the 19th, because I'm traveling to Pune on 20th. So I'm not available. So we'll be connecting on the 19th of. So Dr. Kundan, you are in Pune?
Yes, ma'am. Yes.
So I am going to be in Pune for a number of times this month and next month and next month. This month I'm coming twice, on the 15th, 16th, and 17th, and then on 21st, 22nd. And then again for symbiosis, I'm coming for almost like 10 days. Okay. So as I said, it will help you to understand your conflict resolution style. So your approach in handling conflict will be based on how you handle your conflicts in your personal or professional life. So some of you said that you are accommodating. So the best, image that explains accommodating style is teddy bear style, where like teddy bear, you would adjust and cooperate to a high degree. You will give in to maintain relations. At the same time, the pros of this style is that it will do minimum injury, because you will actually try to make everybody happy. And you would also try to maintain relations. But the problem with this style of handling is that you will breed resentment, because you will not be able to tell people what they are supposed to do or how they are supposed to behave. So that will breed resentment among some part, and in yourself also. Sometimes you may feel that you have been exploited by others. So people who are accommodating, and if they are weak in their position, they are likely to experience exploitation. The next style is avoiding. So like tortoise, you would go in your shell. It's a non-confrontational approach where you want to avoid any kind of conflict. So therefore, you will postpone decisions, you will postpone difficulties, you will postpone issues, because you don't want to take any strong decision which can fall for reaction. So relationships are maintained at least superficially, because you are not confronting anybody. So naturally, there will not be any conflict with them. The cons of such kind of handling is it will breed resentment, because when issues are not handled, decisions are not taken, issues are not addressed, definitely it will bring resentment in you and in other people also. So there will be a lot of unaddressed problem, unresolved issues, which will breed resentment. The third style that you may have noticed is competitive style. So this is represented by shark, where like shark, you are authoritative and competitive in your, Santoshi has written accommodating, teddy bear, and compromising fox. So you will get to know more about compromising. Wait a minute, Santoshi. Okay, so competitive style, like shark, the person would be authoritative and competing in approach. The benefits of this approach is that you are goal-oriented, task-oriented, you are quick, and you look for shortcuts and you try to resolve the issue. The problem with this style is, again, people will be unhappy with you because they are not able to match your style of handling situations. It will also breed hostility because people will not feel comfortable being with you or with the style that you use to handle conflicts. And also there will be some amount of unresolved issues and problems, but people will never have courage to come up to you and say what those unresolved issues and problems are. The next style of conflict resolution is compromising style. So it's represented by fox. So you would compromise depending upon what you want to gain out of that situation. So it's more like a middle ground approach where you try to handle complex issues and you know that there is no one single answer to it, but you try to find a solution which can create a win-win situation for both the parties. And when you know the other party is equally powerful and you know you can't have your say, so you kind of compromise and you agree. The minus side or the disadvantage of this style is that no one is really happy and satisfied because they have to sacrifice a part of their share or their fun, so they will not be actually fully happy and satisfied with it. The next style is called collaborative style, which is represented by owl. So problems are solved in a collaborative way to minimize the negative feelings. The benefits are that this creates mutual trust. People know that you will be fair in your approach. Relationships are maintained. It also builds commitment from both the sides. But the cons are this style is very time consuming. Plus, you may not get the right person on the other side, and it could actually take away a lot of your time and energy. And unless both the parties actually need to have the same mindset, you will have difficulty, being collaborative. And sometimes people can exploit your collaborative approach and take it as your weakness, and they may, make use of that opportunity. So this is in nutshell about the different styles of managing conflicts. So now you know your style of managing conflict. I think you will have some idea how you are doing it and what is a better way of doing it. Any questions about it? No questions?
How long? How
Yes.
long does it usually take to actively change your style, ma'am?
So it's a matter of knowing that, okay, this is something not appropriate or not helpful, and it has its own, pros and cons. And you think it's not helpful, it's a mindful process. See, it can happen like this.
My scores are very close together. My compromising and collaboration are there, but then I see that I think it's again about, like you said, mindfulness, because once the lid is off, once emotions are off, and especially if it is a long relationship when we are set in our ways, sort of automatically that situation creates certain patterns, even though you are knowing. So new relationships, it is easy to apply these things.
Yeah.
Old relationships, it's so hard.
Yeah. So assertion is a very helpful tool in learning the right way, learning and implementing the right way of handling conflicts. So in assertion, you say what you want to say. You show patience and listen to others' point of view. You allow people to say what they, what they feel or they think. If you're able to create, open environment where people can come up to you and say that this behavior of yours was not appropriate, and if you are ready to accept their feedback or their observation, and if you're ready to reflect on it, I think assertion and reflection, these are two tools which will automatically help you with number of new ideas that will help you in handling your situation in future in a different manner. But it again, it's a mindful process, it's a journey. Old habits die hard. You have to work on yourself on regular basis, sit with yourself, ask yourself, where did I go wrong, what I said, what was inappropriate, what else could have I said, how differently could I have handled it. That is where you will start getting answers. And
I think I should be recording my conversations, because once things get, I sometimes can't recall what exactly happened.
exactly. So sooner you reflect, better it is, because then the memory is fresh. You know what you said. So I do a program on emotional intelligence. So I make people, go back to the incidents and then, literally visualize everything step by step. So you get to notice what you said, what was your body language, where you were, where was that other person, what was the situation. So when it is called metacognition. It's called metacognition. So more you do metacognition, more you will get to know how you are handling, what you are thinking, and then you will also have answers coming from within. Because see, we all have a tutor inside that guides us. Do we listen to that voice? That's a question. But for that, we need to go silent. We need to listen to that. Yes, somebody was saying something, I think.
Ma'am, I just wanted to ask, in spite of we having a dominant style for conflict resolution, still in different situations, we might change our style.
Absolutely, absolutely.
Because
so see, mind is very smart. It can evaluate the, most of the times. We know where to show our anger. We know where to speak what. We know where to behave how. It's only when we are completely emotionally hijacked, that is where our control on the behavior gets lost. But otherwise, most of the times, the rational mind is very smart in calculating the safest way to handle that situation.
Because, ma'am, as you discussed all the ways, I understood one thing is that when the person is angry, we should not be angry. We should be able to understand that we have to not take any emotions into that place at that point of time. So we have to keep the emotions out of the box, and then we have to handle the situation. Because if we bring the emotions, then we get caught up.
Absolutely.
Yeah. And that's why we might require different ways to handle the situation, in spite of we having our own dominant style for conflict resolution, or maybe our own behavior patterns.
Absolutely. So there are so many things one can do. One can learn anger management. One can learn empathy, to look at things from their point of view. The moment you will practice empathy, see, for example, if somebody is driving very slow and you are literally honking at his back or her back, and you're very unhappy with the way he's driving, and you're saying, oh, this person does not know how to drive. And when you go closer, you see a sticker on the car that says that the person is physically challenged. Your whole anger diffuses. So empathy would help us, look at things from their point of view and understand their challenges. So such practices do help us learn anger management, aggression management, and also assertion, where the same thing can be said in a manner which is less, disrespectful or less harmful, but still you are able to communicate what you want. So again, when you start learning these things, automatically your handling of situation becomes more professional and responsible. Any other question or point if somebody wants to add or say? Okay, so no questions, then we have the presentation. I think we have 3 people who are going to present today. Are you all ready?
Yes, madam.
Okay, so I'm allowing you to share your screen. Please go ahead and start your presentation. Who's going to do first? Dr. Neha, you want to go?
Yeah.
Okay.
I would
go.
like, if it's
Sure.
okay.
Go ahead. Yeah.
So good evening, everyone.
Yeah.
Today I'm going to share one of my experience in medical error in operation theater. So I would like to start with that. So there was a case going in general anesthesia, and the anesthetist in charge was putting the central line through the subclavian vein. And once the anesthetist put in the central line, he asked the technician who was helping him to, he asked to connect the IV fluid line to the central line port and asked whether there is any backflow of the blood towards the IV fluid bag. The technician said, no, sir, it's everything fine. The fluid is going. So anesthetist presumed that the line is into the subclavian vein and fix up the central line, and went to the other side on the left side to put in the arterial line. So around 10 minutes had gone by, and during this time only I also entered the OT, and I observed that the central line fluid bag was pressure bag was it was bloated, means the pressure was very high, but the fluid was going drop by drop. So I came to that side, and at the same time, the consultant in charge also came to the same subclavian side, and he also observed the same thing, that bag is inflated too much, but the fluid is going drop by drop. Because if the line is into the vein, the fluid with that much of pressure will be running like anything. So both of us asked the technician, what happened to this fluid? I mean, why it is going slow? Is it something kinked? Or so we checked, there's nothing there. And he said this speed is from the beginning, the time he connected the line. At the time the anesthetist had asked him to connect it to the central line port. So then we immediately, released the pressure, and what we saw that the fluid is, the blood started going back to the up to the bag. So that was clear-cut indication that the central line was not into the vein, it was into the artery, which can lead to a lot of complications. So immediately the fluid was stopped, and then consultant in charge took out the line and gave the pressure. So this is the incident. So I think I've narrated it. I think everybody's heard. So I would like to know, how many of us listening to me want to know what happened further? What happened? Was there anything? How many of us are curious to know what actually happened? Did any disaster happen? What was the result? Was there any medical legal actions later on? So can I know that?
Almost everybody has.
I think Dr. Kundan
Yes, Dr. Neha,
raised
we
the
would.
Dr. Manisha also, and Madam is also saying. So this is what is experience sharing, which creates a curiosity into the minds of the listener and the participants, and it makes all the participants very active. They want to hear, they want to listen. So nobody sleeps. In fact, we are in the late hours time, but I suppose everybody now wants to know it.
We completely forgot what the activity is. We just got carried with the situation.
So I think because of the short of the time, madam, I should not be going into the what happened or not. So I think at some other time we can talk about it. But today my topic is for experience sharing, how and what are its what is it, and what are its uses, what are its advantages, what are its disadvantages, and what are the do's and don'ts of the experience sharing as the pedagogy. So I would like to share my slide for that. So, madam, can I share the screen? Okay, I'll just.
Yeah, I've given you the option. Are you not able to share?
Ma'am, I've just clicked it.
Yeah. Yes.
Is everyone able to see it?
Yeah, it's opening now.
So that's what my topic is, experience sharing as a way to enhance participation. And I have already narrated one experience, and there are different ways where we can do this experience sharing. The facilitator can do the experience sharing. The other ways are like it can be we can ask the audience to share their experiences. We can ask the patients or patients relatives to share their experiences. But normally once we ask the audience or the ask somebody else to share their experience, it is more time consuming. So today, that's why I have not asked anybody else from the audience. I have myself shared the experience. So then, if we say this is a learner-centered educational approach that emphasizes the sharing and reflection of personal
Dr.
experience.
Neha, why don't you share your, why don't you go to slideshow?
Okay.
There's a, yeah. Yes, please go for slideshow. Further or right? Further right on the slideshow. Please click on the slideshow.
Slideshow.
On the right, yeah. After animation. No, it's on this top. Or if you're going, yes. Yes, yeah. Oh my goodness. No, again, you can see, yeah. Yeah. Thank you. It's there, yeah.
So the experience sharing is a learner-centered educational approach that emphasizes the sharing and reflection of personal experiences. Learners are encouraged to share their personal experiences related to the topic or subject. And there are different mediums. There can be on written narratives, group discussions, or multimedia presentations or expressions. The learning is enhanced when individuals actively engage with their own experiences and the experiences of others. And the facilitators create a safe and inclusive learning environment, guiding discussions and promoting meaningful reflection. Now this is, I'm sorry, madam, but this is with the click now, it is not going further.
It's not moving?
No, I mean, like with the arrow or whatever. So it's
yeah, you press enter, no? Not moving further?
No. That's what, whether enter or.
Is it got stuck or what? So maybe you can stop sharing once, not stop sharing, but from this slide, so you can go back to the.
Yeah, I was trying to do that, escape, but then again it's.
Oh, it's stopped. Mm-hmm. So maybe stop sharing for a second. Yeah.
Then I'll reshare.
Yeah, try once again.
This come the other slide.
No, I think it's stuck.
Just stuck somewhere, and it has moved down.
So maybe if you are not able to show us this slide, post this in the group, but you can just verbally explain us briefly. Don't read the slide, but just briefly, if you can tell from your experience, what is your learning when you have, researched for this experience sharing as a tool in teaching.
Give me just a second. This was, can you see now?
No, we can't see you.
Just a sec. Just a sec, ma'am. Just 2 minutes. Is it visible?
Yeah, now it is actually, yeah. Yeah, go ahead with this. That's better.
I think I'll go with this view. Is
Yeah,
that okay, ma'am?
Yeah, that's
Maybe
okay.
in the slideshow somehow it is.
Yeah. Go ahead. Yeah.
Is it visible now?
Yeah, we can see. Yeah.
Sorry for that delay, madam. So now this experience sharing can be used by in multiple, besides in healthcare situations, it can be used in other ways like classrooms and professional development workshops, including the healthcare situations, corporate training programs, community engagement programs, counseling and therapy session. Many counselors use this mode of pedagogy. And in the cultural exchange programs, social justice and advocacy settings also it is being used. The personal development and coaching, for this also it is used. Informal learning settings, and in the cross-disciplinary collaborations like promoting innovations, creativity and holistic problem solving. That's the result of this pedagogy. And what are the advantages of experience sharing? That is because it's a real world relevance, and there is authenticity and credibility to it. There is an emotional connection, and there's active learning involved with this, and the diversity of perspectives are involved, and there's a motivation and inspiration involved with this kind of pedagogy. People, when they hear this experience sharing incidents, then mainly the audience are motivated and the inspirations are there, and it has got a long lasting impact. There are certain disadvantages also. It has a limited perspective, and if somebody has a lack of expertise, then they may not be able to appropriately relate with the experience sharing incidents. So one has to be expert into that field when they are sharing that experience. Otherwise, they will not be able to correlate with the things. Variability, quality, and there can be the inadequate variability, because some people may take it in a different manner. If somebody is narrating some experience, the audience, the people sitting there may take it in a different manner depending upon their level of understanding. And that's why there may be inconsistent learning outcomes. And sometimes, instead of what somebody wants to convey, the people emphasize more on the storytelling part rather than what they want to really convey through the experience sharing pedagogy. So that one has to really look into. So what do we have to do in experience sharing? What are the do's of experience sharing? One has to create a safe and inclusive environment, and one has to provide the guidance and the structure, and one has to encourage the active participation. It might happen, like suppose if I'm there and I'm sharing my experience, and I'm not allowing others to get involved into that experience sharing. So that should not happen. One should encourage the active participation, and it should promote the empathy and respect, and it facilitates the meaningful discussion, and there should be the provision of the opportunities for reflection for whosoever are the participants. One should give that much of time so that people can reflect upon it and actively participate in it. The don'ts of experience sharing are: nobody should be forced to participate in sharing their experience. I mean, one has to, like Madam also says, if somebody would like to share their experience, she's not forcing anybody. Then we should not allow judgment or criticism, should not make any assumptions or stereotypes, and one should not dominate the discussion, like only one person is speaking, not allowing others to speak. And one should not neglect the confidentiality. The confidentiality should be maintained. Like I explained, I gave the example of medical error, but I never mentioned the hospital or the name of the doctor or the patient name. Nothing was mentioned. And then one should not focus solely on positive experiences, because if we share only positive experiences, then we of course learn from positive experience also, but negative experiences should also be shared. Like today I have shared a negative kind of experience. There was an error, so from that also there is a lot of learning. So that's what it is. Thank you so much.
Thank you, Dr. Neha. Thank you. Can you please stop sharing the screen?
Yes.
So can I request one of you to give your feedback to Dr. Neha about her presentation? Anyone who would like to take the responsibility of giving feedback to Dr. Neha about her presentation, rather than me giving the feedback? Deepika, can I request you to do it?
Yeah, actually, it was a very good presentation, Dr. Neha. I mean, it was, you were able to convince us why we should use experience sharing in a form of public speaking or in any presentation or training. What I felt could have been a little better was a couple of points. One, I was not sure. I did not make a count of the time. Okay.
We are going to focus on the positives.
Okay. I thought a feedback could be both. Okay.
I want to encourage all of you to start, talking and preparing and making presentations. So I'm sure there will be some, mistakes we all.
Yeah, but I want to complete my negative so that it doesn't actually look like negative, because only negative was about the time, because all of us are tired. That's it. I was not planning to tell anything more. So let me complete what I was trying to say. It was only the time because of the constraint.
Brilliant here.
Yeah, only that, nothing more, ma'am.
Thank you for the feedback. Yeah, I think it was a good presentation, very nicely prepared. You really, and the way you did the activity, that really engaged us. I really appreciate that. Thank you, Dr. Lee. So who is next?
Thank you, madam. Thank you, everyone.
Ma'am, can I present?
Okay, Dr. Manisha, please go ahead. Please don't forget to share your presentation in the group so that everybody can look at the slides later on.
Ma'am, give me a moment. I'll share the screen.
Sure.
Ma'am, are you able to see?
Yes, we can see your screen. Yeah. Dr. Manisha, are you speaking something? Dr. Manisha, are you there?
Yes, ma'am.
Okay.
Sorry, ma'am. I think it got muted.
Yeah.
I'm very sorry.
We thought it's also part of the activity.
No, ma'am. Ma'am, so before we could dive into the topic, I would like to share this illustration with all of you. As you all observe the illustration, I would request everyone to share what do you think the image represents. You can either share in the chat box or one of you can unmute and speak. Please go ahead. So what do you think the image represents?
Just looking into oneself.
Yeah, correct. So how does it make you feel? By looking at the image, what feelings do you get?
I just get a neutral feeling. There is nothing.
Okay. Or the image holds anything, any meaning to you?
So Priya has returned calm with a lot of turbulence within.
Thank you. So we just saw that we can reflect on as simple as an illustration. Similarly, we can reflect on our experiences, our case studies, our day-to-day situations, our progress, and so on. The simplest and the most effective way to do that is reflective questioning. Reflective questioning provides respondents with an opportunity to explore their knowledge, experiences, and ideas. They are thought-provoking and do not have one definite answer. Reflective questioning stimulates deeper thinking, promotes self-awareness, facilitates personal growth and learning. It involves asking open-ended questions to encourage individuals to reflect on their thoughts, feelings, and experiences. It is commonly used in the fields of coaching, counseling, education, and professional development. Few advantages of reflective questioning are as follows. And it encourages critical thinking. It prompts individuals to analyze their thoughts and assumptions, leading to deeper understanding of themselves and their experiences. By reflecting on their own thoughts and feelings, individuals can get insights about their strengths, weaknesses, values, and motivation. Reflective questions help individuals explore alternative perspectives and consider various solutions to problems and challenges. Through reflection, an individual can identify areas of improvement, set goals and strategies to achieve them. And by this, they can achieve personal growth and learning. It boosts interpersonal relationships and fosters empathy by encouraging individuals to consider other people's perspective and experiences. It also has a the flip side of the coin is that it is time consuming. It requires time as well as effort, both by the person who is asking questions as well as the person who is reflecting. So it can be disadvantageous when time is limited. Reflective questions may surface up difficult emotions, difficult emotions and uncomfortable truths that the individuals prefer to avoid. Some individuals are resistant and reluctant to reflective questioning and make it challenging to facilitate. Considering reflective questioning as one of the successful form of teaching, it's important to remember few do's and don'ts to ensure effective implementation of the pedagogy. Few of the do's are: use open-ended questions, ask questions that require more than a simple yes or no, and encourage thoughtful reflection. Listen actively. Pay close attention to individual responses, showing genuine interest and empathy. Be non-judgmental and supportive. Ask probing questions. Encourage deeper reflection by asking follow-up questions that delve into the individual's initial response, reflect, and summarize. Besides that, few things which we should avoid while asking reflective questions are close-ended questions. Close-ended questions limit reflection. Refrain from leading or biased questions. Ensure your questions are neutral. Don't rush the process. Allow individuals enough time to reflect on their thoughts and respond thoughtfully. Rushing may hinder the process of reflection. Avoid interrupting. Now I would request you all to write one reflective question, keeping all the do's and don'ts that you all will ask or discuss amongst your peers and colleagues regarding this presentation. It can cover any of the bases: style of presentation, content of presentation, about the presenter. You can write it in the chat box. You have to write one reflective question considering the do's and don'ts. Before I end the presentation, I would like to share a quote from John Dewey. We don't learn from experiences, we learn from reflecting on the experience. Thank you. Thank you, everyone, for patient listening.
So everybody has started responding to my question.
Thank you, ma'am, for all that support. Thank you so much.
Thank you for the good presentation. Thank you so much. Thank you. Dr. Aparna is there to help us close the session. Thank you,
So
Dr.
last is my presentation is left.
I know, Aditi. Go ahead quickly. Yes, I'm waiting for you to present.
Can you see the slides?
Yes, we can see.
Hold on, I should make it big. Yeah. So good evening, everyone. My topic is handling difficult audience. So what do we mean by difficult? It's hard, the person who is hard to deal with. Difficult people we can find everywhere these days. Dealing with them is a challenge, especially for an organization. Many people believe this is the most serious challenge they face in their professional life and day-to-day life as well. How do they behave? They are disrespectful. They don't take any responsibility, disregard any rules or regulations. They are the most negative people we come across. They are most arrogant and unmotivated. So there are few types of difficult people which I came across and which you might also have came across. The person who is know-it-all, maybe person, negative person, think they know it all, and the complainers, the know-it-all. dominate conversation with lengthy argument, and eliminate others by finding flaws and weaknesses to discredit other point of views. They are most knowledgeable and competent. What is they think? How we should deal with them? We should never ask about their opinion. We should make them believe that their knowledge is an asset to us. It is best to ignore them or thank them for their information. The maybe person. They have great difficulty saying anything that might be hurtful or distressing to anyone, so they do nothing at all. They are worried to take any decisions, be it professionally or be it personally. How should we deal with them? By establishing comfort zone, by using decision-making system, by strengthening the relationship. The negative person. They are the person who feel like they don't have no control over anything, tear down morale, or pessimistic. How should we deal with them? Ask what's the worst that could have happened. We should not argue with them. We should make a distance from them or limit our time with them so that we can have a positive outlook in around us. Think they know it all. Do they know what they are talking about? They do not know what they are talking about, but they have a knack of conversation and act like a professional. How should we deal with them? State the correct facts or give alternative opinion in as much detail as you can. Move on to the next topic as soon as possible. This give enough time to deflate with a little embarrassment possible. The complainers. Nothing it seems is ever right for them. They give little specific information about the complaint. They usually state a complaint and then just walk away. How should we deal with them? We should ask them to do the opposite. Ask for specifics: who, what, when, where, why, and how. View the complainer as a resource. Sometimes what they complain about really is a problem that needs to be resolved. So tips on dealing with the difficult people. Why we should introduce ourselves by initiating contact. Be an active listener, empathize with them, reword and repeat what are they saying, redirect the conversation, focus on the solution rather than the problem, present the options which are available around, be honest with them, remain professional, or gather necessary information. So dealing with such people is like nailing jelly to the wall. We should label them, neutralize them, predict them, inform them, ignore them, or we can also avoid them. We should confront them, discourage them, or expose them, or we should isolate them at the end. So in the end, difficult people are everywhere. Maybe we are one of them, or maybe everyone is difficult during certain situations of their life. Either way, eventually we will need to work or compromise with a person that we think is difficult. To know how to handle unreasonable and difficult people is to truly master the art of communication. As we utilize these skills, we may experience less grief, greater confidence, better relationship. We are on our way to leadership success. Thank you.
Thank you, Aditi. Very quick.
It's almost 10 or 11 o'clock. That's why I need to be quick.
I know. I understand. So who would give feedback to Aditi? Payal, will you? Quickly, and then we finish it. Yes.
Yes, ma'am. Aditi, it's not always so fun to listen to you and hear anything from you. You really make everything, whatever, either it's a role play or today's presentation, you make it very nice and interesting. So thank you for sharing such a nice presentation. It is, I think, the one of the situation which you have faced a lot many times, and you did really justice to your presentations. Thank you very much for sharing this.
Thank you, Payal.
Thank you, Aditi. I think well done.
Aditi is the best actor in the group.
Why? Why I'm the actor?
Can't agree more.
Because no, whenever you are given a role, you play it to the T.
Yes, that's right.
Very realistically, actually. Thank you, Aditi.
So thank you everyone for being there and being very patient and participating actively. Deepika, you wish to say something?
I just quickly wanted to check our next week's session. Will it be changed to 12th or will it be having 14th? I just wanted to check.
Yeah, everybody needs to, I think everybody was okay except one person, I think, if I'm not wrong.
I think Miss Mamta said that she might face it a bit challenging to attend on 12th.
I will not be able to attend the next class. I am traveling to Ahmedabad for a week.
Deepika, I think there is some challenge at my end also that recently cropped up. So,
Okay.
Dr. Aparna also says Monday not possible. So give me little time. Maybe if not Wednesday, what other day we can do? Actually, Thursday, Friday, Saturday, I'm traveling. That's the problem. But let's see. Let me work it out and then.
Sure, ma'am. Okay. Thanks. Thank you, and thanks everyone for responding. Thank you.
Thank you, everyone. I think you all
Thank
have
you, ma'am.
and you have really stayed awake till 11 o'clock. That's something very challenging, I know, after a long day. So, Dr. Kundan, were you there?
Yeah, yes, ma'am.
Okay. So your video was switched off. Dr. Santoshi video was switched off. I thought you're there but not there. But I completely understand. That's all right. So let's meet next week. Actually, I'm so tired today that I can't tell you. I did a recording for a program and that has really taken away all my energy. So thank you.
You are the motivation for us to be here till so late.
I know all of you are each other's motivation now. I think you are motivating me to stay awake and do my job with great responsibility. So let's meet next week. Let me see what day is suitable. Most likely it will be 14th only because 12th again does not suit me. But let's see if we have an alternative. I'll be sharing the feedback form in the WhatsApp group. I've already shared rather. So please give your feedback by tomorrow. Thank you so much. Thank you. And who is presenting in the next class, please write your name in the group. Who are going to present in the next class. Good night. Thank you.
Good night. Thank you, ma'am.